direction?
Wilton.
It is in, hold on, let me get the name right. You have no idea how hard it is to Wilson, no, not Sam Wilson.
Wilson Wallace.
Wilson Wallace Hall.
Okay.
Yeah, Sam Wilson's the one behind us. I believe it's along here. So let's look at an ETSU. I'm going to pause this since the online student stuff is building.
Good afternoon again. Glad to be back. Today we will continue our discussion of program planning, management, and evaluation. Just to refresh our memory of what we covered last week and where we are. So we started class last Thursday. We outlined the two main objectives for this two-week session, which are describing, using an ecological framework, how the different determinants of health contribute to health outcomes, and second, discussing steps and procedures for program planning, implementation, and evaluation. Again, we started the session last Thursday by focusing on the different determinants of health. We identified the different determinants, we defined them, you provided examples of each type of determinant. We highlighted the important interactions among the determinants, and we emphasized that really for public health interventions, meaning policies and or programs, for them to be effective, they need to address not only individual behaviors, but also the broader determinants of health. So multi-level interventions addressing socioeconomic factors, environmental factors, and behaviors will be most effective. We looked at the Health People 2020 framework for developing, again, multi-level interventions and objectives. And then we moved on to our second objective, again, for this module, which is the program planning, implementation, and evaluation cycle. So after we assess community needs and develop our partnership, we start working on our problem statement, identifying our priority health problem for our target community, developing our outcome objective, which defines the future desired level of the health problem. We then review the scientific literature in order to achieve, two things. First, identifying state-of-the-art interventions to address our priority health problem, and second, identifying the risk factors that impact our priority health problem, including determinants and contributing factors. We discussed SMART objectives, and we worked together on an exercise to improve on several examples of objectives to make them SMART objectives. We then did a couple of examples where we started with the health problem and analyzed the problem for its determinants and contributing factors. You will recall in one of our examples, the problem was neonatal mortality. We identified two major determinants of neonatal mortality. Those are risk factors that directly impact the level of neonatal mortality in any given community. And then for our low birth weight determinant, we identified three direct contributing factors. And for each direct contributing factor, we identified two indirect contributing factors. And we said that determinants, contributing factors, again, are both risk factors. It just depends on where they exist relative to the health problem. So determinants are going to be the risk factors whose level directly influence the level of the health problem, whereas the contributing factors are going to be risk factors that influence the level of the determinants, and indirect contributing factors are going to influence the levels of the direct contributing factors. Therefore, we do the problem analysis in a backward fashion. We start with the problem, then work backwards to identify its determinants, work backwards to identify the direct contributing factors of the determinants, and work backwards to identify the indirect contributing factors of the direct contributing factors. We also indicated that determinants and direct contributing factors are universal, meaning wherever you are across the globe, those are the risk factors that will influence the level of your health problem, whereas indirect contributing factors are community specific. So they are going to likely vary from one community to the other. We also did another example where the health problem was breast cancer mortality. And again, we worked together to identify the determinants and the contributing factors for breast cancer mortality. Okay? So once we do this health problem analysis and we identify our determinants and contributing factors, now is the time to select at what point we want to intervene. Okay? Again, if resources are unlimited, we will intervene with all of the determinants of the problem so we can achieve the maximum impact. But resources are always limited. Okay? We're going to have a certain budget, we're going to have a certain number of staff working on our intervention, we're going to have specific time frames, etc. So those, to a large extent, dictate what we're able to do. And so because resources are typically limited, we need to select, what determinants we want to intervene with. We're not going to be able generally to address all determinants. We select the determinant that offers us the best chance of success in achieving the desired outcome. Okay? So if age is a major determinant, we're really not going to select to intervene with age because age is a non-modifiable determinant. Okay, so we're going to again select those determinants that are modifiable and preferably that have evidence-based interventions that have been tried and tested in the field. So for our selected determinant, we develop an impact objective that defines the desired future level of the determinant, and for each of the direct contributing factors influencing that determinant, we develop a process objective that defines the future level of the direct contributing factor for our, again, target population. We also discussed last week that outcome objectives, those addressing the future level of the health problem, tend to be long-term objectives, whereas impact objectives that define the future level of the determinant tend to be intermediate objectives in terms of duration, whereas process objectives, which define the future level of the contributing factor, tend to be short-term objectives. The rationale is that process objectives are typically the easiest to achieve relative to the impact on outcome objectives, and also because typically we need to see a change in the process objective before we can influence the other objectives and see a change in their level. So again, I'm going over this very quickly because we discussed all of this last week. So, any questions about what we discussed last week? Questions, thoughts, comments about the material or the examples that we went over last Thursday? No? 2. So who's gonna help show me how to write with this? I forgot.
Oh, you gotta hit the little,
This one?
the little pin button at the bottom.
That one? That's what I thought. That's what I did. Okay, that's what it's doing. Oh, that's not what I want. I mean, I did this last week. Okay, so you guys had a homework assignment, right? For this week. What was the homework assignment?
Analysis of unintended pregnancies.
I need everyone, please, to focus with me because we're gonna keep moving at a steady pace today. What was our homework assignment? To do a health problem analysis of what problem? Unintended pregnancy, right? Okay. And I suggested that you check Healthy People 2020 to identify, to see what the objectives are and to help identify the risk factors. So, what is the definition of unintended pregnancy?
Pregnancy that is not planned.
A pregnancy that is not planned. What is the formal definition of unintended pregnancy? Did anyone look up the formal definition of unintended pregnancy? I guess not. Okay, so an unintended pregnancy is a pregnancy that is unwanted or mistimed. Okay, so that's and those are actually two different things. But the public health definition of an unintended pregnancy is any pregnancy that is unwanted or mistimed at the time of conception. In what population groups are unintended pregnancies more likely to occur? I'm sorry? Among teenagers and
Low socioeconomic status.
exactly, so among teenage or young adult women, among women of low socioeconomic status, so women with, basically, poor women, and among minority women. So the groups that are at highest risk for unintended pregnancy are teenagers and young adults, women of low socioeconomic status, as was mentioned, and minority women. So groups that are already disadvantaged, right? And what does unintended pregnancy do to those groups, to those disadvantaged groups? Increases, decreases their disadvantage, or what? It increases their disadvantage. Why?
Income in the household will become higher because they'll have more responsibilities.
Teenage girls who get pregnant, what's likely to happen to them? To drop out from high school, right? So they're less likely to graduate from high school, therefore less likely to go to college, therefore less likely to have a good earning job, right? They're more likely to start prenatal care late, more likely to have a low birth weight baby, more likely to experience health problems before and after pregnancy. Unintended pregnancy is also documented to have negative impacts on the infants and the children, health and socioeconomic impacts, and on families and societies overall. And that's why we care, right? That's why this is a public health problem. That's why one of the major topics in Healthy People 2020 relates to family planning, right? So that's the context, the background. So what would you say is one major determinant if our target is to decrease unintended pregnancy or increase intended pregnancy? What is a major determinant related to this issue? Yes, ma'am.
Access to contraceptives.
Access to contraceptives. Okay. What will access to contraceptives impact?
What do you like? The more people, or I should say, the easier it is to access contraceptives, it will decrease the rate of unintended pregnancy.
The easier it is to access contraceptives, the more likely are people to use them, right?
Yeah.
Right? So really the determinant would be, and I'm emphasizing this because we will run into this with your project, the determinant will be the actual level of contraceptive use. Exactly. Which is impacted by access to contraception. Okay? Now, what is another important determinant of unintended pregnancy?
Family planning services.
I'm sorry?
Family planning services.
So family planning services relates to contraceptive use, right? How about another different determinant? If we're trying to decrease, again, unintended pregnancy among teens in particular, we want to increase contraception use among sexually active girls and women, and and what?
Sexual activity amongst them, teenagers.
Sexual activity, which is, what's another term for that? That's actually in those objectives.
Sexual education.
She's saying reduce sexual activity.
Abstinence.
Abstinence. Okay. So, the higher the abstinence levels, the lower the unintended pregnancy rates. And the higher the levels of effective contraception use among sexually active girls and women, the lower the levels of unintended pregnancy. Does that make sense? Is everyone following? Okay. So we've identified, again, at this point, two major determinants of unintended pregnancy. Contraception use, whether or not girls and women use effective contraceptive methods. We said access to contraceptive services is a contributing factor for that. What's another contributing factor that impacts whether or not women use contraceptive methods effectively?
Education and awareness.
Their beliefs, or the
Awareness.
awareness and beliefs, exactly. Okay. So now we've identified two direct contributing factors for the determinant of contraception use. Okay. What impacts in any given community, what impacts whether or not people have access to contraceptive methods?
Availability of services for
So both of these, cost and availability of services. Okay? So access is impacted by availability of services, service provision, our contraceptive services, family planning services available in our community. And also insurance coverage, which affects cost and the affordability of those services. And then what factors affect the level of awareness of people in the community, their beliefs, their education level about reproductive health?
health education and counseling.
I'm sorry?
Health education and counseling.
Health education and counseling in schools.
Mass media campaigns.
So what we call, formal education or school-based education. And then parental education. Are parents having those discussions with their teens? Okay? So again, in any community, the level of effective contraception use and the level of sexual activity are going to impact unintended pregnancy rates. In any community, access to contraceptive services and awareness of reproductive health issues will impact the level of contraception use. And then those indirect contributing factors at the bottom of the chart are community specific. So in some communities there are many clinics that provide family planning services. In some communities service availability is limited. Insurance coverage cost can vary from one community to the other. Schools, whether they have an abstinence-only program or a more comprehensive reproductive health program, that's going to vary by community. And the level of involvement, of parents is also going to vary, not just by community, but by household. Okay? Does this make sense?
Yes.
Okay. So which objective in Healthy People 2020 addresses the level of intended pregnancies? FP1, right? Folks, how many did the homework? So you need to speak up. So FP1, right? Increase the proportion of pregnancies that are intended from the baseline of 51% in 2002 to a target of 56% in 2020, a 10% improvement rate. Okay? Which objective addresses the level of effective contraception use? Speak up, please.
FP2?
FP3. FP3.
Effective contraception use, that's FP16. FP16 increase the percentage of women 15 to 44 years that adopt or continue use of the most effective or moderately effective methods of contraception. And you have the baseline and the target. Which objective addresses abstinence?
FP9.
FP9, thank you. Increase the percentage of, and there are actually two of them. One, increase the percentage of adult females. No, I'm sorry, increase the proportion of female adolescents aged 15 to 17 who have never had sexual intercourse. So FP9. And the baseline 73% in 2010 to a target of 80% in 2020. Okay. Awareness is FP12. Access is FP15. So FP1 will be called what? Your outcome, impact, or process objective in our example. Outcome. Again, in some literature, it may be the impact, but that's okay. FP16 and FP9 are what type of objectives in this example? Impact. And FP15 and FP12? Process. Okay. Now, where would you intervene if you're designing an intervention that will ultimately decrease the levels of unintended pregnancy in a given community? Your intervention activities will be at the level of the process objectives. So for each process objective, for FP12 and for FP15, for each one of them, you're going to develop an action plan, okay, that lists the activities, the tasks that you will need to complete in order to achieve that objective. So if you have two objectives, in this case, FP12 and FP15, how many action plans do you need to develop? Two action plans, right? For each action plan, you develop, for each process objective, you develop an action plan, okay? So you're going to need an action plan to increase the levels of awareness in your community about reproductive health matters, and you're going to need another action plan to increase access to contraceptive services in your community, okay? And the action plan related to increasing access to contraceptive services will seek to increase the availability of services in the community and to increase access to insurance coverage, i.e. to decrease the cost. make those services more affordable, and then the action plan that seeks to increase the level of awareness about reproductive health matters will address school-based policies, parental education, mass media campaigns, and other efforts, tied to awareness. Okay? So the activities in your action plans will relate to the indirect contributing factors. The idea being that you intervene with the indirect contributing factors if you're successful, if you are actually targeting the right indirect contributing factors, that should lead to the achievement of the process objectives, which then should, by itself, lead to the achievement of your impact objectives, ultimately leading to the achievement of your outcome objectives. Okay? Again, this is what we discussed last week. Any questions? I'm just a tiny little bit disappointed that not everyone did their homework. But that's okay. I'm gonna. Drake can be okay about it. Okay, so now is the time to, again, develop our work plan or action plan. So for each process objective, like I just said, for each process objective, your work plan should include, at minimum, the following: a list of the activities or tasks that your team is going to need to implement in order to achieve that process objective. And then for every activity or task, identify the person responsible for achieving that activity, the time frame by which the activity should be achieved, and the budget. Why should we identify the person responsible and the time frame? Why not just list the activities needed to achieve the process objective and stop there? Because nothing will get done, right? So we have to have a champion for each activity. We have to have someone responsible, a leader of that activity. Okay? And why do we need to have a timeline for achieving the activity? To be able to track exactly our progress, right? And to be able to hold ourselves accountable. Are we doing what we are planning to do within those time frames? And why develop a budget for our intervention? Because resources are limited, and we need to know what human and financial resources and other resources are going to be needed to implement those activities. Because nothing happens by itself or for free, right? Everything has a price tag attached to it. So this is an example of a measles immunization program. The objective here is to achieve a 95% immunization rate among 2 to 3 year old children in Washington County, Tennessee by 2018. Baseline 85% in 2014. What do you think of this objective? It's good? Is it a smart objective? It's a smart objective, right? Okay. People in the back, you're also allowed to talk. And you won't be charged extra for that. So examples of activities that will appear in our work plan for this objective would be things like, implement a public education, again, or a mass media campaign to raise awareness about the importance of immunization. Another activity perhaps would be training the providers, the nurses, and the doctors, again, so that they counsel their patients and ensure that those vaccines are being, delivered to those children. We're going to need to do community outreach in order to get our message out to those difficult, to reach populations. We have to do good record keeping, so that's for our internal tracking and auditing. We have to obtain the vaccines somehow. We need to obtain supplies. We may need to hire people. We may need to train people. We may need to conduct evaluation activities. So there are really lots of activities that have to happen in order to achieve this objective. Okay? So part of developing the work plan, part of action planning is thinking through what it's going to take to achieve this objective and listing all of those activities. And again, identifying who on our team is going to be responsible for what and by when. Okay? And you will be doing this for your project, for your team project. Again, you'll identify priority problem, you'll do the problem analysis for its risk factors, select one determinant to intervene with, and then select two direct contributing factors, develop two process objectives, one for each direct contributing factor, and then develop a work plan or an action plan for each of your objectives. The work plans or action plans, they can be drafted, designed in different formats, and there is not one preferred format or another. It really depends on what your team prefers, what your organization prefers, and if you're applying for funding, which typically you will be applying for funding from some funding agency, you need to follow what their guidelines are for developing, your work plan. So if they wanted to use a key activity chart, you will use that. If they wanted to use a Gantt chart, you will use that, etc. A key activity chart is a very simple chart. This is actually what you will be doing for your team project. You will list the activities under each process objective in sequence. So what activities you need to implement first, then next, and so on. So in chronological order, and again, the person and the time period for each. So So in an activity chart, it will really look something like this. You will have your activities. You will have one column where you list your activities. You will have another column where you will list the person or persons responsible, and then the time frame or the deadline by which the activity will be completed. So effectively, in its simplest form, the activity chart will include 3 columns, again, in its simplest form. Here you will list your activities in chronological order. So again, you can start, with hiring your staff, training them, purchasing your equipment and supplies, designing your media campaign, training your providers, etc. And then for each of those activities, you will indicate who's responsible. Is it the program director maybe is responsible for hiring staff and training them? For purchasing the supplies and the equipment, it may be the program secretary. For designing, the media campaign, you're gonna need someone with experience in design, in communication. For your provider training, it may actually be your lead nurse or your lead physician on your team, okay? So depending on the activity, you will identify who's the best person on your team to be responsible for that activity, and then the time frame. So let's say hiring the staff will happen between January to March of 2019. We will train them between February and April of 19. The media campaign will be designed in May, and then it will launch after that, and so on. So again, this is a very simple activity chart. Another common way of presenting your work plan is what we call the Gantt chart. Okay? Anyone seen a Gantt chart? The Gantt chart will be like a matrix, okay, where, let's say this is a 1-year program. Every column will be a different month. January, February, March, April, May, June, July, August, September, etc. And then you will list your activities here. So activity 1, activity 2, activity 3, same as before. Hire, train, purchase equipment and supplies, secure the space, design the materials, launch the program, start the evaluation. But what you'll do here is for each activity, you will indicate when it will start and when it will finish. Okay? If it's a multiple year program, like the last project that we applied for funding for is a 6-year project. Okay? We did not do this by month, we did it by quarter. Okay? So we had for the first year Q1, Q2, Q3, Q4. For the second year, okay? So we actually had 6 times 4, 24 columns, each column representing a quarter. And we listed our activities and indicated, again, what quarter each activity will start and what quarter it will finish. Because again, that's a 6-year plan. For a 1-year plan, you will typically do it by months. Okay? And there are very simple software programs. I mean, you can do this, and you're not going to do this like this, with pen and pencil. I mean, all of this now, there are templates that are automated, and you just plug in, your activities and your X's, and it will produce for you charts that are very pretty. A lot of those programs are actually downloadable for free from the internet. Questions? So now the fun part. What is the fun part? Budgets. So I love budgets because they keep us on track. So now you have your action plan. Again, you have all of your activities. You know what you need to do. You know what kind of people you need to achieve those activities. Okay? So now is the time to put your budget together, to make sure that you have the resources to hire those people, to implement those activities, and to do what you need to do to achieve your process objective. Budgets are typically divided into 2 categories: your personnel budget and your non-personnel budget. Okay? So your personnel budget is going to include your staff, okay, needed to implement your intervention, your team, basically. Your non-personnel budget is going to include everything else: equipment, supplies, communication costs, travel, space, etc. Okay, so those are some of the common budget items that you typically find in any budget. So we're gonna assume that we're working on a budget for a health program, a pretty straightforward health program, where the team is composed of 9 individuals. Okay, so this is a hypothetical example. The program director, 2 health educators, 2 nurses, a part-time physician, a part-time program evaluator, full-time secretary, and a consultant. Okay? So this could be maybe a school-based immunization program or a college-based health education program. Okay? This is not something huge. This is not a statewide program or a national program. Okay? Given what the human resources are. So how do we go about developing our personnel budget? Again, we start by identifying our team members and the percent effort that every team member will need to allocate to our program. So in this case, we're saying we need a full-time director who will allocate 100% of her time and effort to our program. We need 2 health educators who will deliver, again, health education programs at our schools in Washington County, and they will each allocate 100% effort to our program. 2 full-time nurses to administer vaccines or whatever it is that we are doing in the schools across our county. The physician will serve more like a medical director, supporting the health educators and the nurses. So he really only needs to devote 1 day a week to our program. So that's 20% effort. The evaluator is going to be one of the public health professors at ETSU, because we want an independent evaluation, and she will allocate, again, 20% effort to conducting the evaluation of this program. A full-time secretary and a consultant whose time is contributed by one of our partners. So how do we go about determining this budget? First, we start by defining or listing the base salary for each of those positions. The base salary is what someone in this position working 100% effort, a full-time person, will make in our market. Okay? So we need to do some research, okay, to find out if we're looking for a master's prepared director with 5 years experience in health program administration, what is the typical pay rate for this type of position in our market. Okay? So again, this is information that is publicly available. Okay? And we plug that in. We don't look at the rates in Los Angeles, for example, or New York. We know they're going to be significantly higher than in our market here because of differences in what? Cost of living. Okay? So that's why we look at our market. The health educator is going to be someone who has a bachelor's degree, right? So with maybe 2 to 3 years experience. So again, their full-time pay is going to be lower than the director. Okay? The nurses will vary depending on whether you want an LPN or an RN. Okay, so we have to make sure we specify what kind of qualifications we want, because that determines the base salary. Family physician, in this case, their annual full-time salary is estimated at $120,000. And annual full-time salary of the evaluator, 52,000. Annual full-time salary of the secretary is 25,000. So again, those figures are based on our market research and typically published, by the Bureau of Health Resources and other organizations. Once we have the percent effort that each individual will allocate to our program and their base salary, which is how much they will get paid if they were working full-time, that's the full-time base salary. We can calculate their program salary, which is what proportion of their base salary we will allocate to our program budget. Okay? So if someone is working full-time on my project, then my project is going to cover their 60,000. But if someone is only working 20% on my project, then my project is only going to cover 20% of their annual full-time salary. Does that make sense? So the program salary, again, which is the salary that will be budgeted to my program, is their base salary multiplied by the percent effort that they will allocate to my program. Okay? Keep that in mind because you're going to calculate these. Okay. Program salary, again, the salary allocated to my program is their full-time base salary multiplied by their percent effort on my program. Benefits, fringe benefits. What's all included in fringe benefits? What's benefits? Health insurance, if we are providing health insurance, again, the cost of the insurance, the premium or the price of the policy is typically shared between the employer and the employee. I'm sorry? Allowances for what? Allowances for what? Travel allowances will be under travel in the non-personnel budget. So we do not put that here.
Overtime.
Overtime is paid salary, it's not a benefit. Benefits are things that come with employment. Okay, so health insurance is a benefit of employment. What are other benefits of employment typically?
Vacation?
Paid vacation, okay, is another benefit of employment.
Conferences. Paid conferences.
That's allowances that's under non-personnel expenses.
401.
Retirement benefits, okay, are under fringe benefits. Sick leave is under fringe benefits. What else? Annual leave, which is vacation. I think you say vacation days. Yeah. So annual leave or vacation, paid vacation, is under fringe benefits. Some organizations offer disability insurance for their employees, short-term or long-term disability insurance that falls under fringe benefits. If you have an educational benefit, ETSU offers an educational benefit. Every employee of ETSU is eligible for an educational benefit, and a lot of our bachelor's prepared staff, pursue their masters as an educational benefit of ETSU. A lot of our master's staff pursue their doctoral training as part of the educational benefit of ETSU. I can do a certificate now in teaching, so I can become a better teacher. ETSU will pay for it. So that's an educational benefit. Okay? Benefits are typically calculated for budgeting purposes as a percent of program salary. Okay? You contact your human resources office when you are developing the budget, and you ask them, how do I calculate benefits? And they will tell you, it's 25% of program salary or 35% of program salary, depending on how generous or limited the fringe benefit package of your organization is. Okay? If your organization offers health insurance, and life insurance, and disability insurance, sick leave and vacation leave and educational benefit, then this is going to be on the higher end. It's going to be more like 35 to 40% of program salary. But if they only offer fewer benefits, This is gonna be more like 25% of program salary. For our purposes, let's go with 35%. Then you add the program salary and the benefits. This column plus this column will give you the total personnel expense for each position that is allocated, again, to your program, to your budget. You add what's in this final column, and that's your personnel budget for year one in a very simplified form. Okay? So please go ahead now and complete all of those question marks. Okay, you can work with your neighbor. Let's take a few minutes for this one. They should have it. No, I don't have it. You should have this in your slides or on your laptop. So just please, work on it there. Anyone needs a calculator? So again, benefits, 35%. I always get a question. How about part-time people? Are they eligible for benefits?
No.
Typically, part-time people are not eligible for benefits. But just for our practice today, so you can practice working with those numbers, let's consider them eligible and calculate their benefits.
Of that.
Yeah.
I thought I heard 5 and then
35%. 35%. So benefits is 35% of the program salary. We have a generous employer here.
I just wrote like benefits for this company, or she's 30% of her salary. Where'd you go?
The benefits is 0.35 times the program salary, not times the base salary. Okay?
She's been through this service to figure out that. Yeah, sure.
Do you have a question?
Oh, yeah. For the total, for the educators and nurses, are we doubling that in the total?
Yes.
Totally, you just add them together.
So the question was for the health educators and the nurses. Remember, there's 2 of each. So you need to double their total. Okay?
What did you say?
Program salary and benefits, but just make sure that they reflect the fact that you have 2 educators and 2 nurses. Yes, that's what we're saying.
And then this 14, because you double it. So, 131. If anyone in our
Depending on what I'm doing.
Okay, now it's 20%.
I know, I get some of
It didn't like fix it, it didn't like adjust it. It just, yeah.
That's 100% of 60. The 35% still zero.
Are you talking about biostats?
Alright, 20%.
Oh, no, wait. Yeah, she's bad. This trilogy is just taking over my life, so that will be.
Mental math, man, I'm killing it. I ain't
So like
I think this, I think so does it just make it
yeah, and then it would be
So, but like they're not added together.
that's the
Just need to keep putting
the base size will be used to
blue eyes for me.
So that wouldn't affect our.
It's already graded.
Ready? Ready? Okay. So help me out, because I don't know how to use a calculator. Okay, so let's fill those together, and we just go around. So program salary for our director. We'll just go around.
60,000.
60,000. Okay, so again, she's gonna be working full time on my program. So my program is gonna cover her full time salary. Benefits for her.
Oh, 21,000.
I'm sorry,
21,000.
21,000. How did you get that number?
That's 5% of 60,000.
So it's 60,000 for program salary times 35% or times 0.35. If anyone got a different figure, please speak up, okay? So what's the total cost of the director for my program? 81,000, okay? Educator,
40,000
40,000 for one, for two,
for kids in the 80.
for two it's gonna be 80,000, okay? Benefits, for one or both? 28,000 for both. So that's 80,000 times 0.35. And the total cost of the two educators for my program? I'm sorry? 108,000. Okay? Is everyone following? We know how we're getting those numbers? You're gonna be doing a budget for your project. If you don't do it well, Dr. Baker's office is right next to mine. She will come to my office and she will kill me, you know? So, okay, nurses. Okay, so for one of them, again, 50,000 allocated to my program. For both, 100,000. Benefits, next please.
35,000.
35,000 for both. So it's 100,000 times 0.35. Total cost?
135,000.
135,000. Excellent. Physician.
24,000.
And how did you get that figure?
20 multiplied by the base salary.
Okay, so it's their base salary, 120,000 multiplied by their percent effort on my program, 120,000 times 0.2. So I'm basically, my program is only paying them for 1 day a week, right? Because they're working somewhere else for the other 4 days. Make sense? Okay. Benefits?
8,400.
8,400. Total?
60,400.
32,400. Okay. Evaluator.
10,400.
10,400. So that's again their 52,000 base salary multiplied by their percent effort on my program. Benefits.
3,640.
Total.
14,400.
Okay.
14,040. 040.
040. I told you I can do it. Okay. Secretary.
25,000.
Benefits.
6,750.
5,000.
8,000.
750. Okay. And total.
33,750.
33,750. So what's my total personnel budget for year 1?
Sorry, I didn't add them all together.
It's okay. Take your time. Okay. Who would like to help your friend?
Did you do it?
I didn't see that.
404,100.
104.
404, 190.
404.
Our staffing is definitely good.
Okay? So that's my personnel budget for year 1. Okay? That wasn't difficult, was it? It was pretty straightforward, right? That's why I like budgets. Because numbers don't lie. But words, who knows? Okay, we're not finished yet. We have our personnel budget. We now move to our non-personnel expenses. So again, this is where everything that's not staff salary and benefits goes. Okay. Again, this is a very, very simplified non-personnel budget for a program with a very small scope. Okay. Travel is always typically a category in your non-personnel budget. How do we calculate travel? It depends on whether it is travel within our state or out of state travel. So for in-state travel, we have to estimate the number of trips that our staff are going to make. All of those people who were on the previous slide, we have to think about each one of them. Estimate the number of trips that they're going to make during year 1 within our state and the average mileage per round trip. We don't have to estimate actual mileage for each trip. Okay? We just estimate average mileage per round trip and then multiply that by the mileage rate, okay, which is a published rate. So in this example, we're saying our staff will be on 20 trips, will take 20 trips to different areas within the state. They may travel to the state capital, to Nashville. They may travel to different clinics at an average of 50 miles per round trip or 25 miles each way at the cost of 54 cents per mile. Out-of-state travel, however, is not estimated based on mileage. So out-of-state travel for conferences, professional meetings, etc., is typically estimated based on the number of meetings that our staff will participate in. Okay. Typically, the cost to attend an out-of-state meeting, including travel, conference registration, lodging, and per diem expenses, typically that's going to range between $1,500 to $2,500 per meeting. So we're estimating 2 professional meetings. Our director will go to 1 professional meeting. One of our nurses will go to another professional meeting during the year at a cost of $1,500 each. Communication is costs related to internet use, telephone charges, fax, postage, etc. That's a bit trickier to estimate, but we're estimating here $3,200 for the first year. Equipment, we plan to purchase 2 personal computers and printers at $1,500 each, 2 laptops for the work that we will be doing in the field at $1,000 each, a data projector to give our health educational seminars at the schools at $2,000 each, and we will be leasing a photocopier for our office at an annual cost of $600, and then purchasing a fax machine for our office at a cost of $300.
I have a question.
Yes, ma'am.
For the PCs and printers, is it like 2 PCs and 2 printers? Like when you're calculating that cost, is the $1,500 for each PC and then for each printer, or is the PC and printer one?
PC printer combo
Okay.
is $1,500.
Okay.
So we're buying 2 sets. Good question. Office supplies, that's, pens, pencils, papers, toner, cartridge, folders, files, etc. And typically that's estimated at $500 per full-time employee. Okay, not everyone in the previous chart, just full-time employees. And then printing of survey questionnaires and health education materials and other program materials we're estimating at 4,000. Okay? So again, let's take a few minutes and complete the missing cells in this table. Yes, sir?
How many full-time employees were there?
Full-time, how many full-time employees were there? Good question. How many full-time employees? 6, right? Okay, very good. Okay. 6 full-time employees. Okay. You can work with your neighbor.
Oh, we don't, okay.
Wait, I forgot what you said about the trips. Is that 20 trips for each person or just total?
20 trips total. 20 trips total. For everyone.
And for the full-time employees.
Sorry?
And for the full-time employees.
It really doesn't matter.
Oh, okay.
20 trips for everyone.
What did you get? You have the second one you asked the third I'm just gonna drop
So you don't have to do work. That's total. It's the 20 trips. That's how many trips we all
Any questions?
That's big. I don't know what they're doing.
Okay, whose turn is it? Where did we stop last time?
500.
Okay, so what's our budget for year one for in-state travel?
$540.
And how did you get this figure, please?
I multiplied 20 by the 50 miles per round trip, and then I took that total and multiplied it by the 54 cents per mile.
Exactly, so 20 trips times 50 miles each times 54 cents per mile is $540, okay? Out of state travel. 3,000, so 2 conferences, 1,500 each. Communication, 3,200. How about equipment? 7,900. 7,900, and how did we get that figure?
2 PC printers, so 3,000 plus 2 laptop, 2,000, plus 2,000, and then plus 600 and 300.
Okay. Did everyone get 7,900? Yeah?
No.
Anyone got a different figure? No? Okay, this is a safe place, you know. Office supplies?
So I got $3,500 per 6 full-time employees.
So $500 times 6 full-time employees. Okay? Printing 4,000. So what's our non-personnel budget for year one?
21,640.
21,640. Okay? Cool? Okay. So what was the personnel budget? 404. 190 plus the non-personnel 21 640. Then this is gonna give us our year one budget, right? Which is 425 830. Okay? So this is our year one budget, personnel plus non-personnel expenses. Everyone knows how we got there. Now we're gonna assume that our program is actually a 2-year program, because really it's difficult to achieve much within just 1 year. And we're gonna make a huge assumption that our personnel and non-personnel needs in year 2 are the same as our personnel and non-personnel needs in year 1. Okay? So basically we're gonna assume that our expenses, our budget in year 2 is the same as our budget in year 1 for sake of this exercise. Typically, that's not the case. Typically, you would need to develop another budget for year 2 based on your personnel and non-personnel needs for year 2. Okay? So again, in the I mentioned the last project in 2016, we applied for a 6-year research and evaluation study. Okay? We developed 6 budgets, 1 for each year. Okay? And then added them together to get the grand total. But for illustration purposes, we're going to assume again that our year 2 budget is the same as year 1 budget. We have the same personnel and non-personnel needs. In that case, all we have to do is to calculate the year 2 budget, all we have to do is to start with the year 1 budget and increase it by about 4%. Why do we increase it by 3%, 4%, or 5%? To account for inflation, right? Which is the typical increase in the prices of goods and services in our market. Okay? So in recent years, inflation rates in the economy have hovered at around 4%. Okay? So what's our year 2 budget then in this case?
Yeah, one was,
Loudly, please.
444,863.
444?
Sorry, 442. 442,863.2.
Okay. And how did we arrive at this figure?
It's 104.
Okay, where are we? Let's go back to our term. How did we arrive at this figure for year 2?
It is 4%.
So we take 425,830 and we multiply that by what?
By 425.
425,830 multiplied by
0.04. 1.04.
1.04. Okay?
yeah,
That will give us 442,863, which is our year 2 budget. So if we want to increase our year 1 budget by 4%, we multiply it by 1.04. If you want to increase it by 5%, we multiply it by 1.05. Okay? And so the budget for both years is going to be the year 1 budget plus the year 2 budget.
Sorry, that's a question here.
Yes?
Yeah,
Hansa?
can't you do it by 0.04 and then add it back to the original amount?
We can,
Yeah.
certainly.
Okay.
I'm just, I guess, doing it in one step.
I've never seen it done that way. before,
Yeah,
so
I've never
that's why
seen it that way.
Yeah, I didn't know that you could do it that way, so I was just confused.
You never had Dr. Corey before. So our total budget for both years combined? 868. Yeah, we'll round it. 868,693. Okay? So that's the year 1 budget plus the year 2 budget. Now, let's be honest. Who is lost? Who's lost? Who's not sure how we got here? So if I erase all of those figures and ask you to do them again, you can do them in 2 minutes? Any questions about budgeting? Again, this is simplified, for purposes of an introductory course. If you want a real crash course in budgeting, come see me. Okay? Again, you will be developing a budget for your project. So I hope that at least you have the basics now of how you proceed to do that. Any questions before we take a break? Okay, well, let's take a 10-minute break then, and we will reconvene and discuss program evaluation. Thank you. Okay, so at this point, we have developed our work plan, which includes both our action plans for our process objectives and our budget, okay? And it's time to develop the evaluation plan for our program, okay? So evaluation planning. Again, this afternoon we will do a brief introduction to program evaluation. This is, a science in and of itself. In our doctoral program, for example, we teach a semester-long course on program evaluation. The methods and the approaches to program evaluation, but I will try to cover again the concepts today. We can think of program evaluation in terms of three broad types: formative evaluation, process evaluation, and effectiveness or impact evaluation, which is sometimes also referred to as summative evaluation. So effectiveness evaluation, impact evaluation, summative evaluation, those terms are used interchangeably. Okay? And those are different from formative evaluation and process evaluation. So let's start with formative evaluation. Formative evaluation evaluates the development of the program, including the quality of materials and messages. So given this, when does formative evaluation occur? Before we implement the program, during program implementation, or after program implementation? Before program implementation, right? So this is where we are, again, testing the quality of the program materials and messages. The program materials and messages can be anything. It can be our survey questionnaires that we're going to use. They can be our media messages, our YouTube educational videos, the billboards that we're going to put up in our community, the flyers, right? The handouts, the brochures, okay? So program materials and messages will vary depending on what our program is. But each and every material and message must be tested before we implement it, and must be tested with a small group of people from the target audience. So whoever this material or message is intended to reach. Okay? So this, for example, this is the 2018 survey of healthcare providers. Okay? This survey was developed in the spring semester. This is part of the work that my team, is doing. This survey will be mailed to over 3,600 providers next week. we developed the survey to examine the delivery of reproductive health services among family physicians, OBGYNs, and nurse practitioners, based on an extensive literature review and also informed by a series of in-depth face-to-face interviews that we conducted with primary care providers in the fall of 2017. After we developed the survey, one of the first things that we did is we tested the survey with a number of physicians and nurse practitioners in our area here. So I would sit down with the provider, with the medical provider, ask them to complete the survey, not this final version, the initial version, and then go through it, ask them what they liked, what they did not like, ask them to paraphrase certain questions in their own words, so I can be sure that they are understanding those questions the way I mean for them to be. Ask them about the length of the survey. If there are any questions that are not clear or offensive to them. Get their input about how to administer the survey. Okay. And I did that. You know, I sat down with individual OBGYNs, family physicians, and nurse practitioners here in Johnson City and in Kingsport and in Northern Virginia and tested the survey in the spring. And then based on the input that I collected from them, I revised and finalized the survey. Okay. This is another survey that we developed last year. This is a survey of health centers that we administered last year to health department clinics and community health centers in the states of Alabama and South Carolina. This went to the clinic administrators. So who did we test this survey with before we mailed it out to hundreds of clinic administrators? Who did we test it with? Clinic administrators, health department, and community health center clinic administrators in our area here. Refined it, revised it, finalized it, and then send it out to our clinics in the states that we're working in. Okay? So the same is true for, again, media messages, educational materials. Even if we are using a survey that was used before, or a flyer that was used before, why should we test it ourselves?
See if it's still relevant.
See if it's still relevant.
Especially if the community where we are going to apply this time around from the ones we have been connected.
Exactly, especially if the community where we intend to use the materials is different from the community where the materials were used before. So we want to again make sure that it's culturally appropriate, right? That it's written at the language that reflects the level of health literacy in our population, that it does not contain offensive messages given the attitudes and beliefs and cultures of the community that we're working in. Okay? So again, the purpose of formative evaluation is to collect information to help us as program planners improve our program activities. Okay? So formative evaluation, sometimes called quality assurance or quality control, because we are testing again the quality of the materials and messages that we're developing, occurs before program implementation. process evaluation. This is another type of evaluation where the focus is on assessing how well we are implementing the program. Okay? So the questions that we seek to answer here as part of process evaluation are: were the activities performed as planned? The activities outlined, again, in our work plan. Were they implemented as planned within the specified time frames and budgets? And were our process objectives achieved? So basically, the main question that we're trying to answer here as part of process evaluation is, did we do things right? Did we do the activities, the tasks, did we implement them right? Did we implement them consistent with our plan? So when does this occur? When does process evaluation then occur? Before we implement the program, during program implementation, or after program implementation? During program implementation. Okay? A common form of process evaluation is auditing, internal auditing. So every month, the program director should really be revisiting their work plan. Are they progressing? Are they implementing those activities, again, consistent with the timelines within the budget? If yes, great. If not, why? Why are there delays? Why are there gaps? What can be done to correct that? Okay? Because if you don't do that, if you're not engaging in process evaluation, 1 year will pass and you'll realize at the end of the year that you've really only achieved 10 or 20% of what was in your action plan. And that's too late to make that realization. So really, process evaluation should occur on an ongoing basis. Okay? With my project teams, with my research teams, and I currently have 5 different research teams. Okay? Depending on the project, we either have bi-weekly meetings with each project team. All of them actually are bi-weekly, except one project is monthly. But at every bi-weekly meeting, okay, the first item on our agenda is to review our progress. Is to review for the project leader to review their progress relative to their timeline and action plan for the year. Okay. The third type of evaluation, again, effectiveness, impact, or summative evaluation. Here the focus is on determining whether or not, or the extent to which, we achieve our impact and outcome objectives. Okay? So did we do the right things? Did we address the right risk factors that influence the problem? Okay? Keep that in mind. Process evaluation, did we do things right? Did we implement activities as planned? Whereas effectiveness evaluation, did we do the right things? Did we attack the right risk factors? Because if the answer is yes, we should see a change in our impact and outcome objectives, assuming we achieve the process objectives, right? So how do we go about conducting effectiveness evaluation? What are, some of the approaches? So let's, I'm sorry?
I have a question.
Yes.
So for the summative or impact, does it matter to do it right after the end of the program or like 5 years after the program? Does it matter?
So the question is, when does impact evaluation occur, or effectiveness evaluation? And the answer to that, anyone has the answer to that question? When should we start our effectiveness evaluation? Before the program is implemented, during, or after?
No, I'm asking that, is it immediately after, or we wait for some 5 years after?
Oh,
it matter?
both,
Okay.
ideally, but at least after. So keep that question in mind because I'm gonna come back to it in a second. Okay? Oh, yes.
Alright, I got a quick question.
Mhm.
So for the 3 evaluations, would it be best to have that, all 3 in the project? Is that something, or do you pick one?
No, all three,
All
because they
three?
serve
Okay.
different purposes.
Okay.
They have different purposes. Again, formative evaluation is to test the quality of your materials. Process evaluation is to check on your implementation of your action plan and on your budget. Effectiveness evaluation is to see if you achieved your objectives or not. They serve different purposes. Okay. So what do you guys think? Effectiveness evaluation. We start working on it before we implement the program, during or after.
I think during and after towards the end.
So I'm hearing after, I'm hearing during and after.
Are you asking like when you make it, or like when you start evaluating?
When do you start collecting the data to use in the effectiveness evaluation? When do you start working on it? Yes.
So you should always like know what you're going to evaluate before you start it, because that prevents the results from being biased. If you know what kind of trajectory your project is taking, you don't want to evaluate it halfway through knowing like some of your successes and failures, because there can be bias.
It's a good point.
Is it in part based on whether you're looking at the impact or outcome objective, like when you're evaluating it?
So hold on to that. Hold on to this. We're going to come back to it, okay? You're going to reach the answer by yourselves, okay? So, the example that we did today, our outcome objective related to unintended pregnancy, okay? Let's revisit that. So again, it's Family Planning 1 from Healthy People 2020, okay? So let's go to Healthy People 2020. And this week it opened up. So last week it did not want to cooperate. So this is the family planning topic. Those are the objectives. And we said family planning 1 is increase the proportion of pregnancies that are intended from a baseline of 51% to a target of 56%. Target setting method, data sources, data. So how would we go about evaluating whether or not this objective is achieved? Speak up, there's no right or wrong answer. Speak up. So we want to increase, again, the proportion of pregnancies that are intended from 51% in 2002 to 56% by 2020. By the end of 2020, we can evaluate it. Okay.
They do a mid-course evaluation.
We can do a mid-course evaluation. Okay. What kind of data would we need to evaluate this? What data are we going to be looking for?
Maybe health records, abortion rates.
So look here, it tells you the sources of data. The National Survey of Family Growth, right, conducted by the CDC, is one source of data. It tracks intended versus unintended pregnancy. Or the National Vital Statistics System, right? So we know, this is data that is collected regularly on an ongoing basis as part of national surveillance data, okay? So the data should be available on an annual basis. So come 2020, okay? Let's say we're doing this program in our community here in Washington County to decrease intended pregnancies. Okay? And let's say our target is similar to the national target. So let's say now is end of 2020 or even early 2021. We obtain the data for Washington County, the proportion of pregnancies that are intended. Okay? And let's say it is 56%. Okay? And we also have the baseline data. Let's say in 2020, it was 51%. What happened between 2010 and 2020? We delivered the intervention, the program in Washington County. Okay? So this is again data for Washington County. Okay? Baseline, data, intervention, target data. So time flows in this direction. Okay? X represents the intervention, what we did in Washington County to increase intended pregnancies. This is our first observation point, which is our baseline data. This is our second observation point, which is our final data. Okay. Washington County is the experimental group where we implemented the intervention. Okay. What can we conclude now?
That the intervention increased.
That the intervention increased
The intended pregnancies.
intended pregnancies. Can we conclude that the intervention increased intended pregnancies?
Assume that, can't really conclude it.
I mean, if that's the case, why aren't you like all happy and cheering and that you achieved your outcome objective? So what can we conclude? I know it's late in the day, but let's think. We can conclude that the proportion of intended pregnancies increased in Washington County, right? It did increase. But can we conclude that that increase was because of our intervention?
No.
We cannot conclude that the increase was because of our intervention. Why?
So there are confounding variables?
Yes.
Similar to that, it could be that there's a similar program being run at the same time. There could be some policies that also influence that. So attributing it to our program may not be so.
So your friend is saying that it's possible that there was another program that was implemented maybe statewide, right, that affected the rates in Washington County. Maybe there was a national policy that was passed between 2010 and 2020 that contributed to the increase in this rate in Washington County. Okay. What is this called? When there is another intervention, an event not related to our program that occurs during our study period and can cause or contribute to the observed change. This is known as a history bias. Okay? So history bias is an event, again, not related to our program, not related to X, but related to another program or policy that occurred between 2010 and 2020 and either caused or at least in part contributed to the observed change. With this kind of design, there is no way for us to control for history bias. So again, we cannot conclude that our intervention, that X, led to this increase. This design, E01X02, is called the one group pre-test, post-test design. One group because we are only including the experimental group that is receiving our intervention, in this case, Washington County. Pre-test is the observation that occurs before the intervention. The baseline observation is called the pre-test observation. The post-test observation is the observation that occurs after the intervention. Okay? So our pre-test observation in this case is 2010, post-test is 2020. One group pre-test, post-test is a commonly used evaluation design, but it's actually one of the weakest evaluation designs. It is a non-experimental design, and non-experimental designs, again, are weak designs because we cannot control for history or other biases. It's a simple design, it's inexpensive, but it does not control over threats to the internal validity of our findings, again, such as history bias or other biases. Would you say this design, the one group pre-test, post-test, is most appropriate to evaluate your process objectives, impact objectives, or outcome objectives? Would you say that the one group pre-test is most appropriate to evaluate short-term process objectives or longer-term impact and outcome objectives? Short-term process objectives, okay? Because the shorter the time between the pre-test and the post-test, the less likely for other events to occur and impact your second observation. But the longer the time, the more likely for other events to occur and contribute to the observed change, okay? So while it may be okay to use this simple, inexpensive design to evaluate your process objectives, you really should stay away from it, if at all possible, when you're evaluating your impact and outcome objectives. Now, how can we improve on this design? How can we improve on it so we can have more confidence in our conclusions and our findings?
Please, I look at the pre-test, post-test, and post-test. Can you go over it again? The pre-test.
The pre-test is your baseline observation. So in this case, your O1, pre-test. The test is another word that we use for intervention. So pre-test means the observation that occurs before the intervention. Post-test is the observation that occurs after the intervention. So pre-test is the same as baseline data. And the post-test is the same as your target outcome. Other questions? How can we improve on this design to where, again, we increase the internal validity of our findings?
Add more experimental groups?
Add more experimental groups?
Visit your process
add more experimental, add groups, but not necessarily experimental groups. Add
Probably another group for comparison.
another group for comparison or a control group, exactly, okay? So we can improve on this design by adding a comparison or a control group. A comparison group, we use the letter C with a little line under it to represent a comparison group. So if our experimental group is Washington County, what would be an appropriate comparison group? Sullivan County, perhaps, okay? The one concern with Sullivan County is that it's really very close to Washington County. So you can have contamination, what we call contamination bias. Okay, people moving from one county to the other, or even, if you have your billboards in Washington County, I mean, I come from Sullivan, Hawkins every day to Washington County, I'm gonna see them, right? So you probably want another county that's similar to Washington County, but perhaps they don't share a border.
The Tennessee Department of Health just happens to list a few.
Okay.
Marion, West Virginia.
Okay.
Penobscot, Massachusetts.
As comparison for Washington County.
That's right. And then the whole Northeast region as a whole.
Okay. So actually, I would go with Marion County, Virginia, personally, if you're asking me, instead of going with a comparison county in the Northeast or another region of the country. Why? You want your comparison group to be similar or equivalent to your experimental group, okay? As similar as possible. We want them to be equivalent. The only difference between the experimental and the comparison group is that the experimental group will receive X, the intervention, my intervention, the comparison group won't. But you want them to be equivalent at baseline, okay? Similar demographics, similar culture. You go into the Northeast, it's gonna be a different culture, different political environment, perhaps different attitudes, different beliefs. All that affects health outcomes. So you stay in your region, but move a little bit away, again, to reduce that contamination bias. So Marion County, Virginia. We're also gonna collect pre-test data from Marion County, Virginia. And what are we hoping? The baseline rate of unintended pregnancy to be in Marion County, similar to Washington County, 50%, 51%, something like that. Let's say they're a perfect match, 51%. We do not do X in Marion County. Whatever program I'm doing here in Washington County, I do not do it in Marion County. And then 2020 arrives, I collect the same data in Marion County, and what am I hoping to find? What am I hoping to see in terms of the rate of intended pregnancy in Marion County in 2020? Let's say it's 56%. Let's say that. What can we conclude now?
That there were confounding variables?
I'm sorry?
That there were external factors, confounding variables affecting the result.
That there were external factors, and you
that
said
the intervention didn't do anything.
that our intervention didn't do anything. X was useless, right? Because Marion County had achieved the same increase without X. Okay? So X didn't really do anything. Because again, both counties, the experimental and the comparison, increased at the same rate. Okay? Now, let's assume that the post-test observation in Marion County was 54%. What can we conclude now? one person and speak loudly. Come on, have confidence in yourselves, folks. What can we conclude now?
That may have had some impacts.
That our intervention X may have had some impact in the range of about how much? 2%, right? Which is the difference between 56 and 54. Are we following the logic? Okay. So yes, Washington County increased by 5 percentage points, but really only 2 of those 5 percentage points can be attributed to X. The remaining 3 percentage points are likely due to something else that also occurred in Marion County. Okay? Now, what if we find this? In Marion County, 51%, no change. What can we conclude?
Maybe just maybe our intervention has a higher likelihood of causing an increase from 51 to 56.
We conclude that I will take you all out to dinner and we'll celebrate and have drinks and everything because our intervention worked fully, right? This design, okay, where we have an experimental group where we deliver the intervention and a comparison group where we do not deliver the intervention but we collect observations before and after. This design is called the non-equivalent comparison group. Non-equivalent comparison group. Our experimental and comparison groups, again, they're very similar. They're going to be very similar, but not exactly the same. This is part of a family of evaluation designs known as quasi-experimental designs, okay, where again, you can have some confidence, not full confidence, but some confidence that regarding the internal validity of your findings, and some control over history bias and other biases. So we're currently, you heard me mention, some of the current work that we're doing, where the state of South Carolina is implementing a statewide initiative to increase access to contraception and to decrease unintended pregnancy. And ETSU competed for and was successful in securing the grant to conduct all evaluation activities related to this statewide initiative in South Carolina. For several of the evaluation pieces, we are using a non-equivalent comparison group design, where South Carolina is our experimental state, and our comparison state is?
Alabama.
Is Alabama. Okay. How did we select Alabama? We looked at every state in the Southeast region. Tennessee, Georgia, Florida, North Carolina, South Carolina, Alabama, Mississippi, Kentucky. Compared the demographics of all of those states at baseline in 2016 to South Carolina. Compared rates of teen pregnancy and unintended pregnancy. So again, we want our comparison state to be as close as possible. Everyone said, do Tennessee, you're in Tennessee, no? It's not a good comparison. Major metropolitan areas in Tennessee, Nashville, Memphis, there's no such thing in South Carolina. The biggest city is Columbia, the capital city. Population, much larger in Tennessee. I said Georgia. I looked at Georgia. It shares a border with South Carolina. There's a border, it's gonna increase contamination bias. So Alabama was the closest. Both have a centralized public health system, similar Medicaid policies regarding family planning, similar sociodemographics, similar rates of unintended pregnancy at baseline. They don't share the border. Now let's assume that let's shift. We're in the state of Tennessee in 1998. Now you're gonna tell how old I am. We're in the state of Tennessee in 1998. And I'm at the University of Southern Mississippi. And we competed for and got the grant to do all evaluation activities for the statewide Loving Support Makes Breastfeeding Work in the state of Mississippi. We got the grant in late 1998. The initiative had started in 1996 or 1997. No opportunity to collect baseline data. So what do you do in this case? The program planners, they had not, I guess, thought about the evaluation early on. They started implementing, and then they realized, wow, we need to have an external evaluation. Issued a request for proposals. We competed, we got it. Intervention was already up and running across the state. We could not collect baseline data about attitudes about breastfeeding or awareness about breastfeeding or access to breastfeeding or any of that. That opportunity was lost due to the timing of the evaluation. So what did I do? What evaluation design did I use? No baseline data. I used an evaluation design called the two-group post-test. Okay. Experimental group, comparison group, intervention, O1, O2. No baseline data. Two-group post-test. There's no pre-test data. What's the big assumption that I made in this case? I assumed that the two groups are comparable. Now, I did my best job to select a comparison group that was equivalent to Mississippi, but I could not prove it. I could not prove the equivalence of my experimental and comparison groups using data. Okay. So the two-group post-test design is another non-experimental design. Again, it's simple and inexpensive, but we really only use it when there's no baseline data, as a last resort, so to speak. Big assumption that the two groups are comparable at baseline. So again, this is another design that we want to stay away from, except if we're stuck and have no baseline data from primary or secondary sources. Now let's assume for a second that we're not able to identify an appropriate comparison group for our experimental group. So we have an experimental group. Again, going back to Washington County, we have pre-test data, intervention post-test data, but we're not able to identify an appropriate comparison group. So effectively, we're back to the one group pre-test, post-test. Is there a way to improve on the one group pre-test, post-test in the absence of a comparison group? What can we do to strengthen this design some if we don't have a comparison group? Yes.
So we can target members of the community who were not involved in the project as control.
We can target members of the community who are not involved in the project as control. What if the intervention is a mass media campaign that can potentially reach everyone?
Follow-up test.
Hmm?
You can do a follow-up test.
Follow-up test? Help me understand, what do you mean by that?
After you've carried out the first experimental, you do a second one to see how that result is going to be. Then compare with the previous one.
So you do another experimental counting. Okay.
Yeah, just more multiple tests.
You can add observations, multiple tests. Okay? So instead of one pre-test observation, one post-test, you can have multiple pre-test observations, multiple post-test observations. So if this is 2020, we can continue to look at the data in 2021, 2022, okay? And if this was 2010, the baseline, we can also look at 2009 and 2008. Okay? Yes?
Is it possible to improve on this just by using a more rigorous methodology, like mixed method?
We can use mixed methods, certainly. And this in itself improves the rigor of the methodology. What this becomes now, it's no longer a one group pre-test, post-test. This is now a time series design. Okay? And a time series design is a quasi-experimental design that again allows you some control over threats to internal validity. What are you expecting to see? What are you hoping to see? O1, O2, O3, thinking back to the intended pregnancy example. What are you expecting those observations, those figures to be before you implement the intervention? Before you implement the intervention, you're expecting them to be the same, right, or similar, so little change before the intervention. Okay? So that's what your hypothesis would be, that O1, O2, and O3 are not significantly different. Then O4, you're hypothesizing that it's going to be 56%, and that you're going to be able to, again, sustain this change in later years. Yes, ma'am?
Couldn't you also hypothesize that with the intervention and the people of the 2020 would be continuing on that education and you would potentially increase your percentage?
You could. This is a conservative hypothesis, but you can, assuming that the program will go on, or that your intervention will be sustainable, then yes, you can hypothesize that your observations in later years will be higher. Okay? But that again does strengthen that one group pre-test, post-test. The fact that you're not seeing any changes until you implement your intervention strengthens the design and again gives you more confidence in the validity of your findings. Okay? Better yet, if you're able to have a comparison group and collect multiple observations from the comparison group like you do for the experimental group. Now you're expecting all of these to be in the 51% range, your baseline observations in both groups. You're expecting your post-test observations in the experimental group to go up, and you're expecting your post-test observations in the comparison group to stay around 51% or to increase some, but be lower than 56%. This is a multiple time series design. Because you have two groups, experimental and comparison, and multiple time observations. This is also a quasi-experimental design. This is a very strong design.
Can you explain, because I'm getting a little confused with like the 51, the 56, and then why we want to stay in the 51. Can you explain those numbers again, please?
So the comparison group is not getting the intervention.
Okay.
Okay. So your hypothesis, what you're hoping to see is that there's little to no change in the comparison group.
Okay.
Over time, because they're not getting the intervention.
Okay.
There's no X here.
Okay.
The Washington County is getting the intervention, and that's why you're expecting to see an increase in the rates.
Okay.
The comparison county, again, going back to Marion County, they're not getting the intervention.
Okay. So is that why we're expecting the 51 to even go in the control group because they didn't receive the intervention?
Right.
Okay, that makes sense.
Yes.
Just to clarify.
I'm sorry?
What you're saying, just to clarify, please, what you're saying is multiple observations help us to solidify our claim that an intervention from 51 to 56 is actually good.
Yes. Yes. So this design is an improvement over the non-equivalent comparison group design. Okay, it's very similar. You have an experimental group, you have a comparison group, you have a pre-test observation, post-test observation, except in the multiple time series, you have multiple observations from each group, not just one pre-test and post-test. So you're really taking the non-equivalent comparison group and you're strengthening it by adding those multiple observations. Again, to further increase your ability to control threats of internal validity and have confidence in your findings.
Are there preferences when you choose to use this over that and that over this?
So that's an excellent question. When would you use this design versus the non-equivalent comparison group design? This design, you have multiple observations here, right? This design, anytime you have multiple observations, whether it's time series or multiple time series, with or without comparison group, those designs work best when you're using secondary data that is already being collected, okay? Because it's very, very cost prohibitive for you to collect primary data every year from both the experimental and the comparison group. Okay? So if you're collecting the data yourself, more than likely, because of resource issues, you're going to use the non-equivalent comparison group design with one pre-test observation, one post-test observation. But if the data are already available, again, from some surveillance system, some national survey, vital statistics, other source of data, billing data, claims data, administrative data, epidemiological data, then you should always use the multiple time series rather than the non-equivalent comparison design. Again, if you can have access to this data for multiple years at low cost. Now notice, we talked about non-experimental designs, quasi-experimental designs. So in a non-experimental design, there's no comparison group or there's no baseline data. In a quasi-experimental design, you either have a comparison group or you have multiple observations. Okay? So how about experimental designs? So there's non-experimental, which are the weakest designs. There's quasi-experimental designs, which offer varying levels of degree, various levels of control over threats to internal validity. But we really haven't mentioned experimental designs yet. How is an experimental design different from a quasi-experimental design? Anyone has any idea? What is the one distinguishing feature of an experimental design?
Intervention.
It has a control group, not a comparison group. What's the difference between a control group and a comparison group?
One's receiving treatment, one's not.
Both groups do not receive the treatment. The experimental group receives the treatment, the intervention, X. The comparison group does not receive X, and the control group does not receive X. So what's the difference between them? What's the difference between a comparison group C with a little line under it and a control group C without a line under it?
Maybe the random selection of the control group.
Exactly. A control group is established by random allocation. A comparison group is selected. We select the comparison group. We select Marion County as a comparison group for Washington County. We selected Alabama as a comparison group for South Carolina. A control group, however, is established by random allocation. So let's say all of you here, okay? I randomly allocate you to take the on-ground section of 5500 or the online section of 5500. And then I compare the outcomes of the two groups. You don't self-select. You don't decide whether you take the on-ground or the online. Because if you self-select, I cannot compare the outcomes. There's selection bias. But if I randomly, using a random number generator, without you having any control, any say in the decision, I randomly put half of you in the on-ground section, and I randomly put half of you in the online new experimental section. Then I give you a test at the beginning of the fall semester and the final exam. And I compare the results of the online section versus the on-campus section. So if we're assuming that the online section is more advanced, we're using better technologies, cutting-edge methods, then if both the groups score 60 on the exam at baseline, we should see this group going up to 90 and this group maybe going up to 80. We have to make sure that there's an R before the E and an R before the C to indicate that those two groups were established by random allocation. This is an experimental design. Also lovingly known as an RCT, a randomized controlled trial. This is the standard, the gold standard. The strongest evaluation design. The fact that the control group is established by random allocation should ensure that it is equivalent to the experimental group and that there is no selection bias. Therefore, significantly, again, controlling over threats to internal validity more so than quasi-experimental and non-experimental designs, and allowing us to make conclusions with full confidence. Okay. Are your brains completely fried? Questions? Yes, ma'am.
Can you go back to the difference between the quasi experimental design and the non-experimental design?
So a non-experimental design is going to be a design that either does not have a comparison group, like the one group pre-test, post-test, or does not have baseline data, like the two group post-test. That's a non-experimental design. Then those are the weakest designs. Quasi-experimental design is going to have either a comparison group or multiple observations. From the experimental group. So the non-equivalent comparison group, the time series, and the multiple time series are quasi-experimental designs. The experimental design is going to have a control group established by random variation. And that's the gold standard. That's the design that's used, for example, to test new medical devices or medical equipment or new drugs. Sometimes we use the RCT in public health, sometimes we cannot, because the nature of public health interventions does not always lend themselves to having a control group. And sometimes it's not ethical to withhold the treatment from the control group if we know it's effective. So due to ethical considerations and to the nature of public health interventions, we're not always able to use an experimental design, in which case we use the best possible quasi-experimental design. But anytime we're able to use an experimental design, especially for our impact on outcome objectives, we should do so. Because again, that's the strongest design. Other questions? You're looking at me. I'm looking at you.
I'm good. I can't learn anything else today.
She maxed out. So you want to come with me now? At 4 o'clock I have a conference call with my funding agency. I still have to function. Thank you, folks. Take care. If you have any questions, email them to me or stop by and see me, okay?